Hey everyone, thanks for joining. We're going to give it just another minute or so to have a few more people join. If you are already here, please make sure to mute your lines and close out any other browsers that you are currently not using. Thank you. Hi everyone, welcome. We're going to go ahead and get started. Thank you for joining us today. While people are still coming in, I'm going to go over some housekeeping items. Please make sure to mute your lines. We'll have time for questions and answers at the end. You can ask a question by typing a question in the chat box on the right-hand side of your screen. Please close out any other applications or windows that you are not using to conserve bandwidth. The webinar will be recorded and posted on our website next week. I'm excited to introduce our presenters today. Dr. Ashley Darcy Mahoney is an Associate Professor of Nursing and the Director of the Infant Research at George Washington University's Autism and Neurodevelopmental Disorders Institute. Dr. Darcy Mahoney advances the body of research in infant health and developmental outcomes in high-risk infants with a focus on understanding the early brain and developmental trajectories in this population. Dr. Darcy Mahoney is a fellow of the American Academy of Nurses Robert Wood Johnson Nurse Faculty Scholar and a current Josiah Macy Scholar. And Dr. Michelle Stevens is the co-founder of Oath Health. As a Robert Wood Johnson Future Nursing Scholar, her doctoral research focused on understanding stress reactivity during early childhood through cardiac measurements of the autonomic nervous system. Her life's work is to pursue the development and implementation of a comprehensive stress diagnostic tool. Understanding an individual's allostatic load beginning prenatally can allow for more accurate health interventions to prevent early morbidity and mortality related to stress with the possibility of radically extending life. With that, I will kick it over to Drs. Darcy Mahoney and Stevens.
Awesome. Thank you so much, everyone, for joining us. I just wanted to give you all sort of a quick intro into what we're going to talk about. So initially, we had really wanted to talk to you all about identifying pediatric adversity and stress in clinical practice, and we're going to do that today. We're also going to really talk about it in light of a pandemic, and during a pandemic, what can we as healthcare providers, especially pediatric healthcare providers, think about while trying to care for these patients during this time. So I'm going to go ahead and let Michelle kick it off, but I did want to let you all know that you'll be hearing and seeing sort of really as information and data came out as we got it, we tried to insert it into this presentation to give you all the sort of best, most accurate information we could as it relates to pediatric stress and emotional dysregulation during this time.
I'm really happy to be here and with you all today. I actually wanted to wish any nurses in the room a happy Nurses Week. Ashley and I are actually nurses, and we met in nursing school, so we really care about nurses and Nurses Week in particular this week because we want to celebrate nurses now more than ever, given they are at the front line of COVID, serving and protecting us. So yeah, I'm here to really talk about something that's near and dear to my heart, which are stress measurements. And as far as I know, in the pediatric primary care setting, we are only, if at all, focusing on two qualitative assessments, which are adverse childhood experiences, or ACEs, and food insecurity. But these, this chart or list is about what we have qualitatively and quantitatively that are validated measurements or assessments for parents and children's stress. We're not here today to really focus on adverse childhood experiences. Like, if you haven't heard of them or would like to hear about them, please ping us in the chat and we'll be sure to send you over information. But we think that that's talked enough about that we really want to focus on the things that may be more under the radar. I really think that we know that adverse childhood experiences have a dose-response correlation to adult health outcomes, primarily the 7 out of 10 top chronic illnesses that we face as Americans. And so I think if we're not implementing this, and thankfully I live in a state of California that our Surgeon General, Nadine Burke-Harris, is spearheading that initiative for all children to be screened for ACEs and for it to be covered with insurance. But I would really like to focus on how we can get a bigger, richer picture of what stress actually looks like in a child, and not just through maybe some specific experiences. And so my interest is in looking at how a child looks as they respond to their everyday experiences. And that's through autonomic nervous system reactivity. I also wanted to add that the Minnesota Executive Function Scale and the Q-Sort are two scales that are near and dear to my heart because a colleague of mine, Megan Gunner, works with these closely. And one, the MEFS, is for executive function, and can catch a child as young as 2 years of age if they're falling off the developmental curve. And then Q-sort is more or less a assessment for attachment. And we can start that measurement even earlier, 12 months of age. And so I really like those two because they correlate really well with cortisol. Let's see. So yeah, these, you know, they stay pretty much in the research world. I know Ashley has been working with some of these biomarkers as well. But it can be as simple as like tracking baby's weight daily. I don't know if any of you have looked at Babies, the documentary. But if you see any of the series, just watch the first one. Yeah, this one is incredible. Love. I mean, it not only made me cry, but for the first time in like mass media, did we actually have like the ability to see some of my research. So really exciting stuff happening there. And so kind of getting the word out about these biomarkers more and more. The Center for the Developing Child is actually deploying a set of these biomarkers. They're calling it like a battery of stress diagnostics in 5 safety net clinics, 5 to 6 safety net clinics across the US. And those data will be ready in about like a year and a half. So really excited to have some data around how these biomarkers are implemented in pediatric primary care clinics across the US. So I'm also curious if anyone has ever heard of autonomic nervous system reactivity. So if you have, please ping us in chat. Would love to connect. So want to actually talk more about my dissertation research. So my doctoral research actually looked at a longitudinal cohort study at 18-month-olds. And if you know, our lab was the first to look at 18-month-olds. And as you may understand, it's really hard to get any data or 18-month-olds to do anything. So that was an accomplishment in and of itself. But then we looked at 18-month-olds to 36-month-olds. And I'm going to share those data with you. But before I do, I wanted to kind of give you a brief overview of these measurements. So most of you know we have the autonomic nervous system, and we have 2 parts. They work symbiotically, not dyadically, as we may think. So they are not opposing, but rather they have this much more harmonious communicative relationship. And so the sympathetic nervous system, or the SNS, is most commonly summarized as our body's ability to fight or flight. And the parasympathetic nervous system, or the PNS, is our body's ability to rest and digest. Heart rate is defined as the number of ventricular contractions made by the heart in beats per minute. You can see the sympathetic nervous system increases our heart, and the PNS decreases our heart. And the pre-ejection period is actually an expression of sympathetic nervous system regulation, and is the time interval from the onset of ventricular polarization to the onset of left ventricular ejection fraction, and it's measured in milliseconds. And respiratory sinus arrhythmia, or RSA, reflects parasympathetic influence on the cardiac cycle, and is measured as heart rate controlling for respirations. So it's an index. So ANS resting is a term to describe what the ANS is doing under periods of rest. ANS challenge is to describe what the ANS is doing under periods of challenge. And most importantly, reactivity is a term to reflect the difference between challenge and resting. It's quite literally a difference score. So we take your measurement from when you're challenged, and then we take your measurement from when you're resting, and we subtract them to get reactivity. So this is a beautifully sophisticated picture of what these measurements look like when we obtain them. And let's see, I mean, PEP happens real fast. So that's happening in milliseconds, and that's the Q to B point. And then the R to R point is RSA, and that's not only taking in consideration the R to R points of the heartbeat, but also this DZT line, which is a marker of respiration. And so this algorithm that I let the bio researchers figure out is how we get RSA. Reactivity profiles are really exciting because this is a way of categorizing ANS reactivity. So we basically bin the profiles so that we have a much more digestible way of communicating these values to everyday folk and people that don't understand the numbers for face value. And so I think what's important to note here is that this could be a really nice way of communicating to individuals that we collect these biomarkers on, like what this profile may be, what these profiles are, and what profile they may be in. It's cool to see, and my research reflected this as well, that kids less than 3 years of age are typically low reactivity, and kids greater than 3 years of age are typically within the classic reactivity profile. And what's really interesting about this is that, in my interpretation of it, is that kids with lower reactivity are typically more dependent upon their environment to engage them and to be engaged. And so kind of a takeaway from that finding would be that it is critical that support consistent care in that less than 3 year of age environment to support development. And then, the kids are a little bit more independent, they have their own ability to react their environment, engage appropriately. Oh, and please stop me if you have any questions along the way. I have the chat, so I would love to field questions along this presentation and make it frankly a so Ashley, please jump in as well. So important findings, not just of my research, but of the ANS research in general, is that cardiac measurements of the autonomic nervous system are highly responsive and sensitive to changes that occur in an individual's environment. And as you can see from these references, this research has been going on for 30 years. And so we are ripe and primed to get this more out there. And I think another thing that I wanted to point to is that I am really interested in understanding individuals' response to their environment rather than how the environment responds to the individual, and more like how we can give the individual the best tools to kind of experience any environment that they encounter, rather than trying to change every environment and make it perfect and optimal, which seems like a really crazy big task. So RSA and PEP have been well studied, and their relationships to child mental and physical health have been well established. RSA and PEP has been understood in relationship to OCD, oppositional OCD, and so it's kind of exciting how we're starting to link these markers. Oh yeah, RSA and PEP have, and as well as epigenetic methylation, which is one of the markers that I mentioned in the earlier slide, have relationships to autism disorder. And so we can start to understand autism a little bit earlier, or in a more unique way through these markers. One finding that was repeated was that in acute poverty, you would expect higher reactivity. So like when you're going through a stressor, you're super reactive, you know, like deer in headlights, like always on. But then we started noticing that once you're in this kind of chronic stage of poverty, you start to get lower activity, which is like, are you like chill? Like what? How are you? You're still in this like chronic state. What we actually see is that kids start to dampen their response, and they get sort of like more unaffected by stress, which is super dangerous because like stress is not bad. It's good. It's like our body's defense against threat. And so we do not want to get kids to the point where they're not responding appropriately to stress. So even more of a reason to make sure that we're not dealing with chronic poverty. And so, oh, this was another hopeful finding. So a lack of stability with reactivity. So when I look at reactivity over time, it is not stable, which is actually an incredibly cool finding that is very indicative of plasticity in early development. And so, yes, it would be really cool that we can like get a nice hold on what reactivity is and how it works and operates, but it's like way too complicated for that. And so that's kind of cool to see that like, you know, the whole message that I love how the Harvard Center for the Developing Child like kind of states is that it's never too late. Like you can always make a difference and change, and there's never like a death sentence, even due to any sort of experience that you may have. So implications of these diagnostics or measurements is that they're messy, they're complicated. Like I said, like they're not stable. So we must tread with caution and use these more as a guide. Maybe I think I mentioned diagnostic, but we are not there yet. And so I think we would love to get there, but are not. So just want to put that in there. I think profiles are an exciting way to start understanding one's biological predisposition to how they respond to their environment. And what I'm really excited about with these profiles is that we can start to tailor interventions in a specific way for children and give them the best tools. And I'm actually going to speak later on about specific interventions that we can give children based on their reactivity. So we need more studies though that look at ANS profiles and interventions. You know, I name a few, and I think we can do a lot more. So I envision a world that we can start implementing these, and so does the Harvard Center for the Developing Child, in pediatric primary care. And unfortunately, during this current situation we are in with pediatric primary care, we are experience. And when I say rigid, I mean hard to change. When I say antiquated, I mean little to no tech or implementation of independent research. When I say these recommendations are for the masses rather than recommendations specifically tailored for the individual. And single channel, we just deliver primary care through a single channel, which is primarily physical care delivery.
Thanks, Michelle. Did you want to jump to the next slide? I'm not sure. Oh, there we go. Perfect. Awesome. Great. So go ahead.
Can you see?
Yeah, I got it.
Okay.
Thank you. So I'm going to sort of reach back a little bit and kind of summarize a little bit of what we're talking about and sort of back to what we're dealing with right now. And if you could just mute your lines, that would be great. Whoever may have theirs unmuted, that would be awesome. So Michelle, can you just back up one? Thanks. So we know pediatric stress and adversity have a vital link to early brain and child development, some of which Michelle was just talking about, and that this connection can lead to adverse health outcomes in childhood and across the lifespan, really negatively affecting physical health, emotional health, social emotional health, and educational achievement. And so when we talk about all of this in relationship to a current pandemic, it's really important to think about this as pediatric healthcare providers, because pediatricians, pediatric nurse practitioners, we're all doing the same thing, working to prevent childhood disease during health supervision visits and with anticipatory guidance and context management. So in thinking about all of this, I'd like to sort of think about it with respect to COVID-19. Michelle, can you do me a favor and just mute your line for me? Thanks.
It's showing me that I am.
Oh, there you go. Now you're good. So because the virus has spread so quickly, many places have banned large groups, specifically, as you all know, schools, which is really what's a lot of our children are being impacted by. And so when kids can't go to daycare, childcare, school, not only is this really stressful for families for all the reasons that probably some of you are dealing with in person, but also some of your patients are dealing with, it can actually cause some really important stress responses in kids. So I'd like to sort of delve into some of that as we're sort of giving this boots on the ground example. Next slide. So while the CDC currently reports the risk of exposure of COVID-19 is pretty low for young Americans, and when I say that, I mean specifically children, research on natural disasters make it clear that compared to adults, kids are more vulnerable to emotional impact of traumatic events that disrupt their daily lives. And boy, has this been a disruption for all of us. And kids are really no different here. So amidst this COVID-19 outbreak, everyday life has changed for them, and it's going to continue to change for them over time. And sometimes children really go under the radar in this sort of what we're noticing and what we're talking about with the emotional impact. I think it's important to recognize that a lot of people haven't talked about kids a lot. One of the very few world leaders that have talked about kids was actually the Prime Minister of Canada, where he went on to say in sort of his like address to the nation when they first started their lockdown, that kids are part of this, that we need you too, and really spoke directly to them in an important way that engaged them in the process of understanding that they also will feel a difference. And kids may struggle to make these significant adjustments to their routines, maybe more so than adults. Often these sort of changes in routines interfere with their sense of structure, predictability, and security. And young people, even infants and toddlers, even those really small babies, are keen observers of their environments. They notice and they react to stress in some of the ways that Michelle talked about that we can now measure. And they react to stress in the people around them as well, what their parents and their caregivers are feeling. For some of the older kids, even just younger school-age children, 4 and 5-year-olds, they may have direct questions about what's happening now, what's happening in the future. They have worries. They may express those worries, or they may act out in different ways. And so while most children will eventually return to their typical functioning when they receive that sort of consistent support from sensitive and responsive caregivers, others are still at risk for developing significant mental health problems, including trauma-related stress, anxiety, and depression. And children with prior trauma or pre-existing conditions can really exacerbate those feelings, especially with respect to parents struggling with mental health disorders, substance misuse, or economic stability, and really have heightened risk for emotional disturbances. So I just want to really focus our time here as we think about stress. Let's really think about it in the climate that we're dealing with. Next slide. So the next thing I want to make sure we're bringing to the forefront here is that parents aren't just worrying about money. They're changing their behavior to compensate for lots of things: steady income, fears, financial instability, and also food insecurity. We know with the closure of schools, where a lot of children got a lot of their main sources of nutrition for certainly breakfast and lunch, that food insecurity is real. This data comes out of California, and we can see here, I'm not going to really go through absolutely everything, but over 1/3 of parents themselves have skipped a meal as a result of coronavirus. And that we see that that number increases significantly among new parents, those parents of 1 to 6-month-olds. That's really important sort of finding for those early young parents, the moms who are at risk of postpartum depression. Parents whose children who've enrolled in early intervention programs and Head Start, people in poverty, really those are the parents that have missed quite a few of their meals. And then And just looking at the children that have missed meals, right? Not only are we, of course, concerned about parents, but looking at all of the different kids who have skipped or reduced meals. In less than 2 months, this has translated to more food insecurity than we've probably seen in such an acute period in a really long time. Again, this data from Los Angeles has shown that single parents, Latino parents, and parents whose children have been enrolled in early intervention are disproportionately more likely to report making a difficult decision to skip or reduce their family's meals. And so as we think about health equity and we think about stress, we can already know beyond just sort of what we're seeing about how COVID disproportionately affects Black Americans, we can also see how this time can really disproportionately affect families of minority families, families in poverty, and this is the work that we're sort of dealing with on the front lines. Next slide. And so sheltering in place has been an emotional roller coaster. I imagine for all of us on this on this WebEx, we all feel that. Our kids are feeling it too. Our kids across the country are feeling this emotional roller coaster. The coronavirus has been disruptive and put parents and young children's well-being at risk. Some data out of California also shows that most parents, 75% of parents, say that coronavirus has significantly disrupted their home and family lives. I don't know if we would probably do an informal poll right here, looking at people from across the country, we might see exactly that same data. We know that people are worried about all kinds of things, but 3 out of 4 parents, so 72% of parents, are worried about their child's social, emotional, and cognitive development. They worry that it's going to suffer as a result of coronavirus, and the same amount report their own high levels of stress during this time. So they're worried about their kids' emotional, social, and cognitive well-being. They themselves are stressed. And 1 out of 4 parents worry about the impact of substance abuse and domestic violence on their family during this time. These are striking numbers. These are the numbers where when we think about what are we doing as healthcare providers, how are we teaching the next generation of pediatric workforce to deal with the repercussions of what we're seeing in COVID, I think these are profoundly important things to think about. When we have families under this much emotional stress, where is the role of nurses, nurse practitioners, and pediatricians? And how are we doing? Where are we doing it? And what exactly is it that we're providing families during this time? We're going to talk about that in a minute. Those are rhetorical for the time being. Next slide. So how do children cope with stress during the coronavirus pandemic? I pulled this photo off of the University of Cincinnati Children's Hospital, and I thought this was just exactly what so many of our families' houses are looking like right now. So how do you help your child through fears of uncertainties during this time? You make developmentally informed decisions about what kids need to know and what they need to understand to feel safe. Kids do vary on the developmental trajectory of what sort of input they have, right? 1 5-year-old may be able to read and 1 5-year-old may not. And so what you see on a screen or not see on a TV is sort of important for families to understand what their child can take in. We should all, and families should focus on creating an environment where children can ask questions that matter to them, that we can reassure children that they're going to be safe, and that as their caregiver, as their parent or grandparent, auntie, uncle, that we will be taking steps to ensure that they are safe and really getting that across to them. Encouraging compassion for vulnerable people and expanding your child's circle of concern. Is it possible that you could have them deliver a meal to the doorstep of someone who might need it so that they can understand that that person might not be able to leave and that they are providing this compassionate care or, sort of neighborly service for them. To that sort of same end, avoid stigmatization, avoiding that by emphasizing that getting sick is part of being human and we all need each other to feel safe. And there's not just one group of people getting sick, but lots of people that potentially could be getting sick. Next slide. So what sort of behaviors should parents be looking out for and thinking about? And sort of really focused on during this time. So emotional and behavioral changes in children are expected during a pandemic as everyone adjusts to changes in daily routines. I think we all have had sort of emotional and behavioral changes, even as adults. We should probably expect that in our children. Some children may be more irritable, some more clingy, some may need more hugs than they're used to or than you're used to getting. Some may regress, some may demand more attention or have difficulty with self-care, with sleeping, and with eating. New and challenging behaviors are natural responses, and adults can help children move back to some sense of normalcy to bring their stress levels down by showing empathy, patience, and calmly setting limits when needed. With strong emotional support from adults and communities, kids can return to their typical level. Most kids will return to their typical levels of functioning. In this slide, I gave you guys just a few ways to do that. I would encourage you to also look through Child Trends and 0 to 3, as they have a lot of really wonderful resources. But creating a physical and emotional environment by practicing the 3 R's: reassurance, routines, and regulation. So reassuring children about their safety and the safety of their loved ones, giving them a predictable routine, which can be really challenging when we're homeschooling and working and cooking and all the other things that we may not always do in our house. Supporting regulation skills by helping them manage difficult situations and making time for emotional check-ins. And then ensuring the presence of a sensitive and responsive caregiver. And some of that is really just being that buffering person for the stress responses that a child is seeing. Next slide. So here are just a few ways that parents can support their kids. So some of these I already gave to you, but I wanted to make sure that I had sort of a layout of some of these things for you all. Again, some really great work out of Child Trends that you can really think about what a child might need. So understanding, again, reactions may be different. Being present. Social distance may not mean social isolation, right? Getting on those Zoom calls for preschoolers, having grandma or grandpa be able to read them a book through whatever, whatever media means possible, whether it's FaceTime or Zoom, etc. Giving them age-appropriate information, keeping them busy, increasing their self-efficacy, right? This is a time when we can really opt for more play. We can opt for children to have more play-based learning, have them think and imagine in ways that we didn't have them perhaps do before out of necessity. Creating opportunities for caregivers to take care of themselves, and seeking professional help when a kid needs it. Next slide. So that's where I just wanted to bring in a couple other pieces here. So Michelle, if you could go just to the next slide for me.
Yeah, I think we had a question. Did someone have a question?
I'm sorry, false alarm.
That's okay, no problem.
All right, yeah, no problem.
So this is where I wanted to really think about what is our role? What is the role of healthcare providers? And how can we begin to think about what we need to do to support children and families during this time? So again, this data is out of California, and I found it really powerful. So they really surveyed, they went out and surveyed 600 parents and basically asked if we could provide things for you, the government or public services, hospitals, if we could provide something for you, what would you want? What do you need? And access to health and wellness professionals through telehealth and technology like a computer, tablet, or phone was the #1 thing that people wanted. I found this to be frustratingly sad, frankly, that we weren't doing this for people. That not only did they want it, but somehow we weren't giving that access to them. That we weren't giving them what they needed. We also sharing examples of resources to help parents support their child's emotional, social, and cognitive development while they're at home. So really, 1/3 of parents said they've missed a health appointment for their child due to coronavirus. 94% of parents wanted more access to a doctor or pediatrician for telehealth. Less than 1/5 were actually able to do so, right? 94% of them wanted it, and 18% of them actually had access to it. In addition, it seemed like a significant problem that many families were not receiving early intervention and home visitation services that they need. So nurse home visiting, OT, OT, some of those early intervention services that they often got, we're not giving to them. And all of these issues are absolutely compounded by a lack of access to technology and a digital divide that we know exists. So I just wanted to sort of bring that to the forefront in we as healthcare providers perhaps have a really important role in at least the 3 arrows that I've pointed out here, and at least giving parents access to us, sharing important examples of resources where they can have supports for social, emotional, and cognitive development, which is directly in the wheelhouse of pediatric clinicians. And when possible, connecting parents to resources that can help with at least health in this bucket that I have that 3rd arrow to, but certainly if we can give them access to things like food through WIC clinics, certainly if our social workers in our offices can help with that, should we have them, those are connection points where pediatric providers are imperative. So I'm going to let Michelle sort of bring the next part of this through where we can really be innovative.
Thank you, Ashley. Yeah, I share similar sentiments of Ashley in terms of that telemedicine stat. That is staggering to me because I live in Silicon Valley. Telemedicine should be table stakes. Like these companies are a dime a dozen. I don't know if you've ever heard of 98.6 or Cirrus, MD, but like if your practice doesn't have telemedicine, you can easily get plugged in to one of these digital apps. And I'll kind of go into why this makes such a difference, but as you can see, people are clamoring for it, wanting it more than anything else. So if I come from the perspective that telemedicine is table stakes, well then what else do we do to kind of make the visit rich? I mean, I think we've accelerated the 5 to 10 years of time it would have taken to get, you know, telemedicine into like the hands of everyone. Like it's within a month. It's happening now. And so how can we really make the visit, the televisit, you know, rich? My husband actually did a telemedicine for derm, and literally his doc did FaceTime. So I think we could be using additional diagnostics, and they exist. TytoCare is a company that I'm specifically interested in because they are, this link is not working. Sorry, they're doing like an array of diagnostics. So everything that's connected, let's see, otoscope, ophthalmoscope, stethoscope that actually prints out an EKG. And so really cool stuff there. An infant scale, UCSF is actually doing a like similar to like a shared hospital breast pump or kind of, you know, what is it, like a loan. They're doing this with infant scales so that we don't have to bring these, you know, critically newborn, fragile infants into a COVID environment. So I think that's a brilliant way of getting more connected. And then bilirubin blankets as well can be used in the same way so that we don't have to bring kids into the hospital and admit them, but rather get their billy up through these technologies. And then another point I want to make about telemedicine is that typically we think of telemedicine as just like to communicate, just to, you know, be able to have this like single exchange of information. But what if we also thought about it to promote adherence? So adherence to, of course, like medications, but also to maybe treatment plans, to alert them to engage in a certain way, to remind them to do something, to check in. Literally, my pediatrician, who is like, I mean, I think one of the best pediatricians, right? Because everyone makes the best decision for their kid. But he has not checked it with me yet. Like, has not had any way to kind of say like, hey, how's it going? Like, how are your kids? And so that's a bit unsettling. And then you can also use telemedicine to help gamify. So we can, you know, have a certain reward system for doing so many things. And this really helps motivate behavior change. And parents, I feel, are the most engaged They'll do things for their kids that they won't do for themselves. So this is like a really important time period, and also like they're engaging with the healthcare system more than at any other point in the life cycle. So this is a time where really we can connect them for their child, but then hopefully as they're connected for their child and see how great it is, they'll connect for themselves. One thing I am super passionate about is around the ethos or statement that health happens in community. It doesn't just happen to one person at a time or one body part at a time, which is how we typically think about it in the West. But it happens to all of us. And we could have seen COVID-19 coming way before we did if we would have thought about it in this way. So one model of care that I really appreciate, and I hope you've heard of it, and if not, please look into it. It's called the centering. Let's see if this would, yeah, okay. So the centering model is an incredible model, and you as a practitioner can get certified in it. They literally use groups as a way of delivering care. So care is delivered not a one-to-one model, but a one-to-many. And if you can imagine, this helps care delivery in so many ways in terms of provider efficacy, in terms of allowing people to be vulnerable and to feel supported by one another, to not feel alone in the provider-patient relationship, to maybe have advocates or have others be like, oh yeah, I'm doing that as well, or oh yeah, that reminds me of this, or I've also experienced that. So groups are a great way to, I think, deliver care. And especially when it comes to childcare. So I want to take the centering model and get it digital. So I would like to do this through chat groups. And what we've done at Oath is match parents, particularly mothers, because we did a national survey and understand that mothers, 80% of mothers are the primary decision makers for their children's health. So we group mothers based on similar characteristics. So where they are in the parent journey, so their child's age, predominantly, and in pregnancy, where they are in the gestation period, even trying to conceive phase is a really important group to match. And then also based on geographic location. So a lot of information sharing is like what you do and where you go to get it. And so we think geolocation is really important. And then also to meet offline instead of just online. And then also, just similar life interests. We think that there's a big divide between like women who work outside of the home or inside of the home. So maybe having similar life characteristics would be important as well. So matching, not just kind of like throwing someone into a group or just having people join without purpose. Because this is how you get like these big like Facebook chat groups that become really dogmatic, and parents start to say things and maybe not have such a supportive way of responding and talking to one another. But if they bond, then there's this really beautiful conversation happening. Within these groups, putting a facilitator within each group. And so kind of assigning a facilitator to each group allows the kind of what I was talking about with like kind of guide or walls around the protective things around the group to be able to encourage group conversation in the healthiest way possible. And then they also flag issues to providers. So these facilitators are actually like, you know, people within the community that are like supporters or champions of women and really care about this conversation happening. And then they can flag the issues to providers to go ahead and do virtual visits. And then optimally, and like 98.6 and other, once you capture this information virtually, it can more easily go into like an EMR and health record. So that's what we actually want to do. We want to get a better picture and fuller picture on health. Right now, if you're kind of like, I don't even want to pay for 98.6 or Cirrus, like get it up on WhatsApp Business. It's free and it works. I mentioned Oath is what I'm working on, but the other innovative care model is Cortica that I'm familiar with. But Oath is modern care for the whole child. It's interested in capturing health as it's happening. So not thinking of health as, you know, episodic, where like you go into the office and receive care and then leave, and then you don't see your provider for another, you know, however long. For some kids, it's, you know, once a year. And so we believe health happens 365 days of the year, 24/7. And so we believe in a model that embeds in the daily lives of individuals. And I think this is how we're actually going to get a definition of human health. I think this is how we are going to start moving the needle on health outcomes. And another very specific thing I would like to change in pediatric primary care is having a lighter physical footprint. So if we're doing more digitally, if we're, you know, kind of cropping 70% of the visits off from in person, then we can actually take up less space. And so less CapEx, and be able to really even think about the physical space differently, like waiting rooms. They're basically petri dishes for kids. So let's get rid of them. So Cortica is another model of care that they basically have this whole child perspective for kids with autism. And they have these specialty services that are within their model. So they are the specialty care providers. They don't like refer out. These specialty care providers are within their institution. And so that's really important too, because you can then almost guarantee the way the care is being delivered and the way the information is being received, and so that it can all be in kind of one place. And it's also much easier for the parents, so they're not going all over the place to get these services and kind of stitch them together themselves, or wait on months on end to get a visit. And then they also incorporate the biomarkers that I included. They're doing incredible things with EEG. So like actually watching a kid do like an executive function test, like that's while on EEG. So like really cool stuff. Highly recommend you guys look into them. Oh no. Okay, so they're primary care interventions. Sorry for that cutoff. But so primary care interventions that I am a big proponent of are the ABC intervention and the FIND intervention. So the ABC intervention I was actually working on after my doctoral degree, and this intervention is for parents. And there it is. Okay. And it was developed by Mary Dozier to help caregivers nurture and respond sensitively to their infants and toddlers to foster their development and form strong and healthy relationships. And we can start doing this as early as 6 months of age. And it's evidence-based. It's actually looked at even in comparison to their RSA and PEP, like I talked about earlier. And so it's incredible to see that basically what happens is that it's usually a licensed psychologist goes into the home and has visits where they're just really giving cues and feedback to the parents as life is happening to help coach the parents, you know, just foster the best relationship and development for their child. Huge proponent of this intervention, and I know we're running short on time, so I'm going to kind of breeze through these, and hopefully the links will come through on your PDF. Another really great set of interventions are for adolescents through the systematic review. So these interventions are actually categorized by outcome. So here we have, like, if you're worried about stress, like here's some mindful, these are some interventions for kids in high school. Let's see, depression, anxiety, suicide, and other drug use. So really cool interventions there for kids or for adolescents. And then we have considerations for the provider. And I want to be able to support you all. I think Ashley had something that you wanted to mention in terms of education.
Yes, thanks, Michelle. So I know a lot of us on the call, just based on the population that we reach from the collaborative, are educators. I know a lot of us educate health professions students, whether it's in nursing, medicine, dentistry, et cetera. And I think one of the things that I really wanted to make sure Michelle and I are bringing forward right now is I'm hoping some of this information is not new to you, and I'm hoping some of this information stimulates you all to think about it. But what I'm also really frustrated about from my own position as a faculty member in the School of Nursing is how we have not integrated our students into some of these telemedicine remote opportunities. We said clinical was over from a face-to-face perspective, and that we were going to be moving everything online and sort of simulated experiences, which has a role, which is really, really important. But I wish that we would have done a better job of incorporating our workforce, our next pediatric workforce, into really this exciting opportunity that was iterative and not perfect and didn't look great and wasn't everything it was supposed to be, but was boots on the ground, telemedicine, telenursing. We had nurse home visiting as like one of the great examples that moved an entire portfolio of home visiting online to sort of this interactive video recording back and forth. We had entire populations of pediatric providers and pediatric health clinics do the best that they could with moving as many visits as they could online, perhaps not as many as I think we would have liked to have seen, nor as much outreach as we wish there would have been, but there was a real opportunity to engage students in this, and at least from a nursing perspective, I can't speak to my physician colleagues, I don't think that happened quite as much as we wish it would have. Our nursing students and medical students did lots of other things to really be volunteers during this pandemic period. But I think as institutions of higher education, I'm not sure that we were the ones that were facilitating this. So I think we'll stop there because we only have about 5 minutes left, and then we do want to give a few minutes for questions. So I think Claire will open it up to anybody that has any questions at this point.
Yeah, if you guys have any questions, please type them in the chat box and I'll read them out loud so they're just a part of our recording. Thank you both for a wonderful presentation.
Well, I'm just to let you all know, we did type a few questions in at the end. I'm not going to go over them in the interest of time, but when the webinar gets posted, Michelle, if you just want to scroll through a couple of questions that we had heard from people before the chat that people had questions to, we wanted to make sure we answered, which some of them were things like, should parents limit families' exposure to news coverage during the pandemic? Some of that I tried to answer throughout the talk. So there's some other a little bit more detailed responses to that question. Before we take this question, I see that there's one in the chat box that says, schools currently provide services with IEPs. How can we help them tailor to these stresses during the pandemic? Such a great question. So I'm going to take part of this, and then I know Michelle, since she's a pediatric nurse practitioner, probably deals with this much more than I do as a neonatal nurse practitioner. But what I can say is that there is a really important role for pediatricians and pediatric nurse practitioners or pediatric providers in general to make sure that we are linking up with the school nurses and the teachers to make sure that in the current circumstance where children have a really different home environment than they had before, that districts are accounting for that and making sure that no child gets penalized for the home environment that they come from. Michelle, do you have other things to say about IEPs?
I couldn't. Something about my screen wasn't allowing me to unmute. I actually don't, but I want to kind of just say that I wouldn't rely on schools, at least the public school system in San Francisco. They're really taking kind of like a hands-off approach because they're really concerned about disparity. So like if we do services for one, or if we do them in a certain way, such as with technology that like kind of limits who has access to what, and we don't want to create this sort of like disadvantaged environment, rightfully so. But I do want to kind of say we might not want to rely on schools at this time, given the kind of constraints that are on schools. So if we can kind of look to other ways to really intervene.
Also, while we're here, I'm going to drop the link to the chat box, drop the link to the evaluation in the chat box. If you can fill that out, we appreciate any feedback.
All right, well, we're just about at 1:30, so I'm really grateful that we've had some time with you all today, and I hope you all are also managing your stress as well as the children that are in your care. And so we are happy to help provide some more information or any other resources that we can. All of our slides will be available, and all will be hyperlinked for you all to use whatever you need for yourselves or the people that you're caring for, both your patients or your families.
Thank you both so much.
Thank you.
Thanks, Claire.
Thanks, guys.
Thank you.